like you feel that physicians are immune to a fact that is true in every other industry, that when AI comes in, some people lose their jobs.
Well, I'm not questioning that. That is reconfiguration of that. But first, that point about expense. We're talking about software here. This is not expensive. So, yes, if you can reduce the need for physicians, which I actually do think that right now the Association of American Medical Colleges that oversees our medical schools and our physician over, the whole workforce, they say we're 120,000 doctors short over the next few years. Mm-hmm. And I say, no, we're not sure at all. In fact, we may have a surplus. But that is the factor of AI coming in and the things that we've been talking about, Magna. The point being is it's not expensive, and the health systems that can deploy this, this is already getting implemented in. I just spent the last year and a half working with the UK to do a review of the NHS that I was commissioned for, working with. That's, as you pointed out aptly, that's not a fee-for-service profit type system. That's a single payer system that works exceptionally well compared to our system with far better outcomes and already is deploying AI. So, I've already seen other parts that we know China is way out in front of AI in healthcare compared to this country. But by seeing these other models in other parts of the world that don't have these perverse incentives, it's easier to be upbeat about where this can go.
Yeah, and why?
Well, the ones that are kind of leading the front are those that are pattern recognition. So, in fact, even beyond radiology of reading scans, the eye diseases are way out in front now. So the ability to diagnose eye disorders of the retina and other conditions, we have seen remarkable deep learning algorithms to process that. Then I already mentioned the scans, and then, next the pathology slide, and then skin lesions, particularly skin cancers. Those are all kind of in the front line as far as lots of data, lots of very promising publications, and those will certainly get very early adoption. But the other one that's pervasive is liberation from keyboards, from speech recognition. That will affect all clinical encounters, and that will be a welcome change.
Mm. You also talk about how AI very quickly could help tackle a major problem in medicine in the United States, and that is misdiagnoses. What can artificial intelligence do to help that? Because we have more than 10 million incorrect diagnoses in this country every year.
Yeah, actually more than 12 million a year. So it's a really big problem. And it's because when doctors see a patient, they have what's known by Danny Kahneman as system one thinking. That is, if they don't think of the right diagnosis in the first seconds of seeing a patient, they're not going to get it. So we have lots of misdiagnoses. If we have machine support, we've already seen how that can markedly improve the diagnosis. And when you start with a patient on the wrong footing, with the wrong diagnosis, all sorts of bad things can happen. Certainly not good outcomes, unnecessary testing, for example. So, this is a really important area that we will see ameliorated because the essential part of this deep neural network can take data that humans can't see or process. So, for example, a gastroenterologist doing a colonoscopy, there's a very frequent miss of polyps, small diminutive polyps that are quite important for colon cancer. Well, now with machine vision, that's not going to happen. It's going to be exceptionally rare to miss a polyp. There are a lot of pulmonary nodules on a chest x-ray, which could be lung cancer, that are missed by radiologists, but will not be missed by deep learning of films, of x-rays. So the list goes on and on about how machine vision, when it's trained for millions of, whatever, it supersedes human capacity.
Well, let's go on the air.
Hi, thanks for taking my call.
Go ahead.
Hi, I was listening at the very beginning, and you were talking about the effects that AI could have on the insurance industry. And I used to be a medical underwriter in Canada in the 80s and 90s, and we were just starting to have the issues of Now that we have DNA and computer analysis of DNA, the fact that you could go and look at people's future medical conditions, are we allowed to base our decisions on what someone now might be able to be told by a computer that they're predisposed to? And what do you do with that information? And how do the insurance regulations and laws affect that? And so that was just my comment to tell you I probably complicated insurance, but made it better for the insurance company, maybe not so good for the client. I'll listen offline.
Yeah, Narissa, thank you so much for your call. Dr. Topol, this is going to come up again and again because I think it's, in terms of, it's the other side of the equation, that what may be great in the doctor's office could not be good for patients when it comes to insurance companies and the whole rest of the healthcare field in the United States. What do you think about that?
Well, one of the reasons we have such a mess in the United States is because we cook. We do too many tests and too many medications. But particularly, that's because we don't understand each individual, the uniqueness, the so-called deep phenotyping. And so we, instead of having all women undergo mammography every year or two, and we know that only 12% of women will ever have breast cancer in their lifetime. Now we have the ability with polygenic risk scores, for example, to know who is at risk and who is not. And so when we add this information to what's already known, that's just one example, we can use the tests that we use as mass screening today, or the same medicines that we give to all people that don't work in lots of the ones who are taking it, and be much smarter. And so that's part of this immense data per each person that we're not using today because we're not yet in this mode, but we will be. And it's going to be to the advantage across the board because we're already 18% GDP. We're already at over $11,000 per person in the United States being spent, which is 2 to 3 times more than any other country in the world. And we have worse outcomes than 36 other countries in the developed world. So something has to give with this horrible business model that exists, and insurance companies are not really the solution to the problem.
Who's going to...
In the book, I get into that in depth. That is, every individual should be a civil right to own all their medical data. That isn't the case in this country, but it has to go there. And the reason it has to go there, Magna, is because you're generating your data. Soon you'll have sensors, not just for steps, but for other important metrics like your blood pressure or your glucose or whatever the condition is you're monitoring or trying to prevent. You also will have your genome sequenced. You don't want to have these data, or you can't have these data, coalesce with your medical record. And not only that, but most people, almost all, have lots of different doctors and hospitals. They can't even get all their data together. What we want in the era of AI is from the time you're in the womb to the very moment that you're trying to assess something, that all that data are input so you can get the best output for guidance. And hacked. We've got to get out of that mode because that's not going to work.
I'm Magna Chakrabarty. This is On Point. Dr. Topol, when you mentioned that, we can hopefully positively use AI from basically it's just the womb to the tomb, that reminded me of a sentence early in your book. Remember how at the beginning of the conversation we talked about that infant boy who had the undiagnosed seizures until he went to that particular hospital that used AI to help process a lot of information about him? I mean, in that portion where you tell that story, you say, few hospitals in the world today are sequencing the genomes of sick newborns and employing artificial intelligence to make everything known about the patient and genomics work together. Now, I was very taken by this example that you gave, but I have to admit, it also reminded me of a particular movie. Can you guess which movie I'm talking about?
Oh, you're going to bring up Gattaca.
I am. Because, look, back in 1997, it seemed like sci-fi, but you're talking basically about this real-life story that mirrors a scene early in the movie. I just want to play this for a second and then ask you a serious question about it. So, 1997, Gattaca, starring Ethan Hawke, and early on in the film, doctors sequence newborn babies' genomes to identify their future health issues. Future being key there, with just a drop of blood. So in this scene, you're going to hear a doctor reading out the medical future of Ethan Hawke's character, Vincent Freeman, just moments after his birth, and Ethan Hawke is narrating.
Now, only seconds old, the exact time and cause of my death was already known.
neurological condition, 60% probability. Manic depression, 42% probability. Attention deficit disorder, 89% probability. Heart disorder, 99% probability. Early fatal potential. Life expectancy, 30.2 years.
30 years.
That's from the 1997 film Gattaca. Dr. Topol, I mean, you are talking about a present and near future where something akin to this might be possible.
No.
No?
I disagree.
Okay.
When I talked about newborn sequencing, I was talking about sick babies in the neonatal intensive care unit, not a healthy baby with output like in that preposterous, Gattaca movie. So, that's a big difference. I'm not saying that all babies should be sequenced. I'm using the technology, which is this is a really important point of on point here, that you're using the technology for the right reason, the right technology for the right person at the right time. So everything was wrong in that movie, and it gave genomics a bad name, unfortunately.
Well, let me just push back on here. I agree with you. This is about using the technology for the right reason at the right time. My question is, do we have the regulatory environment set up to help guide those kinds of decisions? Or will a company out there who says, look, we can sequence the genomes of babies very quickly, and, parents, we can tell you in advance the kinds of diseases to look out for your child, even if your child seems healthy right now. I don't actually see that as entirely out of the realm of possibility unless we have some sort of common set of rules about what the right uses for AI are.
Well, sure. I mean, we've already seen that with CRISPR, with the China use prematurely, recklessly of using genome editing of human embryos, where I wrote the New York Times op-ed about. I mean, any technology can be misused by rogue cases like that, and AI is powerful, just like CRISPR genome editing. That's one of the downsides of when you have something this powerful. And yes, you'd like to have the right governance, the right regulatory, but this is a book which has been written to try to help map that out so we don't have these kind of mistakes and misuse of a powerful tool.
Well, Dr. Eric Topol is author of the new book, Deep Medicine: How Artificial Intelligence Can Make Healthcare Human Again.